My guess is, like many of you, I was more familiar with the work that the CDC does and HRSA does, and sort of had more interactions and relationships with them in the public health department where I previously worked. One of the main players in implementation of the Affordable Care Act is CMS. And in order for us to get this right for people at risk and living with HIV, CMS will play a critical leadership role. And that's why Dr. Stephen Cha is here, the Chief Medical Officer at the Center for Medicaid and CHIP. And you know, in DC, there are a lot of smart people working on this. I have to say, Dr. Cha is one of the smartest people working on this. So it's just really my pleasure to bring up Dr. Stephen Cha to talk about what he's doing and what his team is doing with regard to the Affordable Care Act and HIV with regard to the National HIV/AIDS Strategy. Dr. Cha.
Thanks so much for that overly nice introduction. It's hard being the third panelist on a federal panel because to a large degree I think what I have to talk to you about is basically everything Jono and Laura just talked about. But I'll say a few things, which is, and the first overview piece in terms of what we're doing to prepare for the ACA expansions and transition, you know, the list of tasks would fill this wall, and we have Gantt charts and flow charts that would in fact fill this wall. It's 22 days till open enrollment, not that we're counting, but we're very hard at work to ensure that this transition happens as smoothly as possible. So rather than go through the litany of activities that we're involved with, I think there are three key questions that I think we need to continue to ask ourselves at CMS in partnership with all of you and in partnership with our folks on the stage. And let me just say on that front, we are collaborating more strongly than ever, I would say, in terms of trying to ensure that we don't have these gaps between the agencies, that we have a unified vision and flow towards our approach toward these activities. I talk to these guys constantly in terms of how we're trying to approach these problems. What are you hearing from your grantees? What does that mean for our implications in our programs? And I don't take that from a standpoint of being a good partner. This is about, from our program standpoint, addressing the high needs of an important group of beneficiaries, and how do we best do that and draw from the knowledge of our partners around administration. It's a key central point and one we take very seriously and we've been very invested and involved with for at least my time at the agency. But the three questions that we continue to ask ourselves is first, how are we going to ensure that everyone's enrolled? And on that front, I would make a plea to everyone in this room to continue thinking about that calendar, that 22 days till open enrollment and that January 1 date. You all face these beneficiaries, you see them. We need your help. We need your help to ensure that they get on the programs, that they get the insurance and the coverage they need, that they're really seen in terms of the system. You guys know those systems and what's happening in your state and where those pockets of beneficiaries are better than anybody. And I think my first plea is just a request for all of you to continue to work with your partners in your state, whether they be the exchanges or the Medicaid program, the patient navigators, all the tools we've made available to try and ensure that we have that transition onto full enrollment. It's critical and we're asking for your help and we appreciate the work that you're doing already to date. We know many of you are fully engaged in that. So the first is, how do we really think about getting them onto our programs as we know we can? The second is really, in this early phase, how do we think about ensuring that they get what they need from a benefit standpoint? How do we ensure that they're getting the drugs they need? How do we ensure they're seeing the right providers? How do we ensure they have the right benefit package? How do we ensure that our Medicaid benefits are meeting this new world and the new challenges? How do we negotiate between Medicaid and EHB? I'm not going to stand here and say we have all those problems cracked. But I am going to say here that we have a firm commitment to continuing to work on these in an aggressive fashion, to listen to you all, to hear what we're hearing from the states, continue to hear from our partners in terms of what kinds of lessons we're hearing, and act aggressively in terms of responding to those problems where they may arise. I think we're hopeful and confident that there will be a smooth transition for many, but we recognize that we need to continue to think about the casework that's needed to ensure that all beneficiaries get the kind of care that they need in the new world. Those are sort of two of the early questions in terms of how do we think about this early on in 2014. The promise of ACA was much more than about getting insurance. It was much more than about getting benefits. It was ultimately, and that care cascade slide comes to my mind a lot when we talk about this. The ACA was about how do we fundamentally change the way we're taking care of our beneficiaries? How do we fundamentally improve it? When I look at that care cascade slide, it says to me, our status quo isn't good enough. It shouldn't be good enough for us just to say, let's go into 2014 and make sure we don't lose anybody. That shouldn't be our goal. It should be about how can we really take that foundation of Medicaid coverage, learn from the successes of Ryan White and CDC and all of your work out there, put that into a delivery system reform, combine those ingredients to create a system that truly changes the course of this epidemic in this country. That's what we're really interested in from the CMS perspective, and I think we have a real promise and opportunity to do that if we work together. I can't commit to you that this is going to be something that happens January 1. It's not. I think we are, in fact, very focused, and I think rightly so, in terms of triaging our challenges, in terms of getting our beneficiaries standed up in the system and getting them into flow in that system. But I can tell you that there isn't a state in the country that isn't thinking about how do we really improve care for these beneficiaries once we have them on our systems. Those conversations are happening now with our state partners. They're going to continue, and they're going to get more active, and we need your help in those conversations, not only from the state perspective, but to learn from all of you in terms of what's worked. What are those models that we really should be building upon into that transition into 2014 and beyond? What's that long-term vision for really changing the flow and taking those real core benefits and adding them to a care delivery system that's truly meeting the needs of the beneficiaries? That's what we're focused on in terms of trying to think about that. So it's not always a public conversation. Some of these pieces are happening in terms of how do we unpack this? How can we really think about using our tools and authorities in a different and perhaps more aggressive manner? And I think one case in point, I think, is something Jono mentioned, which is the issue about the preventive care benefits. We heard for a long time from many community-based organizations that we have a great program. It's evidence-based. It's really meeting the needs of our beneficiaries, and you, Medicaid, won't pay for it. So we went back inside and said, okay, well, we do have this regulatory barrier that says we'll only pay for licensed personnel, but we do have this evidence we can't ignore, that there are proven models out there to think about prevention provided by providers who may not have a license but are otherwise qualified. And that's what led to a lot of the preliminary work and finally to the final rule that went out in July. I think it's a symbol. It is not all of what we're trying to do, but it's a symbol of how we are trying to be responsive to the lessons that we're hearing from the field in terms of what's working and not working, and how are we really promoting the best evidence-based care, and how are we sometimes a barrier, and continuing to move forward in terms of iterating our own ability to change those lessons in terms of as we move forward. The last thing I want to mention in this frame is that we have a number of authorities in terms of delivery reform, whether it's health homes, and many of you know about that, and there are 4 health homes, 10,000 beneficiaries in health homes focused on people with HIV and AIDS. We have new flexibilities in terms of our what we call our integrated care models. We're putting out a whole bunch of new TA. We just put out an informational bulletin on superutilizers, this idea of hotspotters. I can't think of something more germane to the superutilizers than the beneficiaries that you serve. So there's a whole range of both TA and authorities and financing in terms of some of our waivers and other authorities. The last thing with my last 10 seconds, I realize, is that second piece of the question, which is really how are we thinking about the ACA moving forward. I think I've talked a lot about that, but just one final point to make, which is, and I think Laura hit upon this as well, which is that there's nothing more important than full insurance coverage. I'm a primary care doc. I see people with HIV, and a lot of them have been uninsured. I think I'm in DC, so we're moving to a situation where that's not true anymore. That change has been really a paradigm shift for the beneficiaries that I see in my clinic. We expect to see that paradigm shift around the country. So it's just an urge that we're not going to just cover the children. We will cover the parents. We're not just going to cover people with their health who's so deteriorated that they've qualified for SSI. We will cover people with disabilities, and before they get to the point where the health's deteriorated. We're not going to just cover pregnant women. We will cover women who aren't pregnant as well. I think this idea of moving beyond the categorical nature of Medicaid expansion to a vision where we'll treat the people and address their needs regardless of what our arcane category they fit in. That's the real vision that the Medicaid expansion really holds. So I urge you all to continue those conversations in your own states. Thank you. And to continue to engage in terms of thinking and partnering with all of us to think about how do we really move that vision into reality. Thank you.